So good afternoon and welcome to the Utah Rural Health Association webinar on mental health. My name is Dr. Charlie Smith and I'm the Regional Administrator for the U.S. Department of Health and Human Services, Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA. SAMHSA is the lead federal agency for mental health and substance abuse with a mission of reducing the impact of mental illness and substance abuse on America's communities. I'm honored to moderate today's panel discussion. We have an outstanding panel of distinguished leaders in Utah's mental health system, and we're equally honored that you have joined us today for the conversation. Approximately 1 in 5 individuals in the past year have experienced a mental illness. And in Region 8, which includes Utah, Colorado, Montana, Wyoming, North and South Dakota, depression, anxiety, and suicide are above the national average. In addition, our rural communities often struggle with inadequate financial resources, well-ingrained misunderstanding and bias towards mental illness, and significant workforce shortages. While these statistics may appear grim, Region 8, and in particular Utah, has made remarkable progress in mental health prevention, treatment, and recovery. From robust community-led efforts in mental health promotion, to depression and suicide screening, to integrated behavioral health and trauma-informed care, to loan forgiveness programs for specific mental health practitioners, to telemental health services, and supported housing and supported employment programs, individuals with mental illness are effectively managing their symptoms, achieving independence, and living healthy, meaningful lives with hope and not shame. And now, with the coronavirus taking hold across the country, the emotional strain has spared no one. Our lives have changed, and with this change, it's normal to feel scared, anxious, and helpless. It also reminds us the importance of staying dialed in to our emotional health and wellness. We are not helpless, we are in control, and we can take action. We can be optimistic and hopeful. We can listen to public health and medical experts regarding COVID-19 because accurate and current information gives us control to manage our expectations and reduces our stress and anxiety. We can also practice healthy behaviors. We can reduce exposure to COVID by practicing the CDC guidelines as well as physical distancing. We can eat, sleep, be active, take our vitamins, brush our teeth, and keep a routine, as well as we need to stay socially connected because we don't want to be alone when we're worried or stressed. We are strong, we are resilient, and we will persevere. SAMHSA has a number of resources specifically on the connection to mental illness and COVID at www.samhsa.gov/coronavirus. And a final note, this upcoming May is Mental Health Month. This is a time to recognize our effective mental health programs, to build relationships and strengthen our mental health system, and it's a time to celebrate the lives of bravery of individuals and families struggling with mental illness. There are a number of great resources within Utah, specifically the Utah Division of Substance Abuse and Mental Health, Utah's Community Mental Health Centers, the Utah Primary Care Association, the University of Utah, Intermountain Health, and of course, SAMHSA. So before we get started, a couple housekeeping items. We'd like to thank our sponsors for their generous support, and they are all listed there on the slide. And we would definitely like to thank all the providers who are on the front line serving individuals impacted by COVID-19. Today, we are using the Zoom video platform. Many of you are probably familiar with Zoom, but for those who are not, you should be able to see and hear each of the panelists, as well as see a number of kind of buttons and features that allow you to change the screen. There's a chat box function, there's a question and answer button, and so forth. We are recording this webinar, so you'll be able to go back and view any portion that you may have missed. We have 4 panelists today who are going to introduce themselves and then provide a brief presentation about rural mental health. And after the panelist presentations, I'll moderate a short discussion with all the panelists. And then finally, to wrap up the webinar, we'll have a couple of minutes for questions and answers from you. And during that time, you can use the Q&A button at the bottom of the screen to ask those questions. Our total time is pretty condensed today. We only have about 50 minutes. So we will move pretty quickly to make sure there's time for your questions. Throughout the webinar, we invite you to use the chat button, which is on the bottom middle of the Zoom screen. That way you can share what you're doing in your communities as well as any actions you plan to take to promote the issue of mental health prevention, treatment, and recovery in your local community. And finally, in order for you to obtain your continuing medical education credits through the American Academy of Family Practitioners, take note of the instructions at the bottom of the sponsorship slide. So with that, let's go ahead and get started. I'm going to pass the baton to Ashley Heaton from Southwest Behavioral Health. Ashley.
Hi, everyone. My name is Ashley Heaton. I am the prevention specialist for Kane County. I work for Southwest Behavioral Health Center. I'm also the coordinator of the Kane Community Coalition. We are a substance abuse and suicide prevention coalition. And I'm also the co-advisor for the Kane Community Youth Coalition, which is a youth coalition that is also a substance abuse and suicide prevention coalition. One thing that I really wanted to focus on with this session is what our main issue was in our community and connecting together. And one thing that we found through research and local data is that people in Kane County, which is a county of about 5,000 or 7,000 people. I live in the main city of Kanab, which is about 5,000 people. We are pretty spread out. It's about 2 people per square mile. One of the main issues that we have here is people just don't know what services are available to them. We are limited in a lot of our services, and sometimes we have to travel outside of our county to get them. And we wanted to come up with a way that we could get those services out there, let people know what is available. And one way that we've done that is we've partnered along with Mental Health Awareness Month in May, and we hold our Mental Health Awareness Day. This is a full day. We have free dinner for families. We have prizes. We have fun activities like bounce houses, lots of things at this activity. And it's really centered on mental health awareness and suicide prevention. One thing at this event that is new that we started doing last year is provider booths. This is one way that we wanted to let people know what really was out there. So we contacted providers from all over our area. That included Washington County, even some from Salt Lake County, and we had them come down and have booths. And it was really great because these providers got one-on-one provider interaction. People got to ask questions from the providers. What kind of services do you offer? And we didn't just focus on mental health facilities, but we also focused on healthy behaviors, healthy eating. We had USU Extension with their Food Sense program. We had local spas there, a lot of different things, local things for families to do. And it was really great. And then also with these booths, we had resources. So each booth had a resource that they could give to these families or these people. And what was great was that it was specific to our area. We also compiled a USB drive that was full of resources for our area. So every single counseling agency in our area was listed on this USB drive, as well as a printed handout for those that didn't have access to a computer. And then also we gathered data. So we had local participant data, which is great because there isn't a lot that we get down here. A lot of times when you're looking at data for your area, it's the whole Southwest region compiled into one, which really doesn't tell us a lot for our area. But we were able to do surveys and get a lot of data from that, you know, on ways that we can help our community link to other providers and what they're struggling with and how we can help link them together. If you could go to the next slide, Amy. All right, so this is just some of our pictures from our Mental Health Awareness Day. So we did have a lot of things to entice people to come. One thing we found is that you can get people to come to things if you offer free food. So we had free dinner for everybody. We had cotton candy and popcorn and all sorts of fun things, as well as bounce houses for the kids to play on. It kind of enticed families to come out and have just a fun time. We painted hope rocks. So we have rocks that people paint positive messages on, and then we have a plot of land out at our local reservoir that is a mental health awareness rock garden. So it has a bench. People can bring those rocks out there. You can take a rock. And then there's also a resource number out there, so a link to the local suicide hotline. These are just some pictures of our provider booths. People, if they went to a certain amount of booths, got an entry to get a prize, which was great. So it got people going to the booths and talking to these providers one-on-one. And it really has been a great event for our area. We get an average about 300 people that attend. So for a town of 5,000, I think that 300 is great. One thing that I found that it does is it really helps to lower that stigma associated with mental illness. When you see all these people out there supporting mental illness and supporting suicide prevention, it lets you know that, we're all in this together. If you want to go to the next slide, I'll just.
Allison, before you move on, we have a question in the chat box. If organizations would be able to do a booth like this again this year, if that's going to be available.
So we are having a hard time this year because it is May. It's done in May, at the end of May, and we're not sure if we'll be allowed to hold big events, but we may be pushing it off to the summer. And yes, we would love to have organizations. So what I've done is, this is the resources page. I have included a Google Doc, which has an example of our registration for booths. If people would like to fill out that registration, they can send it back into us. But also feel free to copy any of this. If you want to do this for your community, go ahead, use whatever you would like out of this Google Drive folder. I really want everybody, to be able to do something like this if they want to. And also feel free to contact me. That's my number and my email.
Thank you very much, Ashley. Let's turn now to Janelle Robinson with Huntsman Mental Health.
Hi there. Thanks so much for having me. Happy Friday. I'm here at University of Utah Neuropsychiatric Institute, and what qualifies me to speak to you as our rural healthcare community. And I'm from rural Utah, so I hold that strong. I grew up in Price. My family is still there. I actually always thought I would be moving back, but have found my career here in Salt Lake. So I am grateful for the rural community and can appreciate the challenges with mental health for the rural communities. If you could go to my slides, that would be awesome. I just wanted to give a quick overview as to, for University of Utah, for UNI, who we are. I think many of you know who we are, but next slide. We are a academic medical center. We have missions of both research, education, and patient care. So there on the slide, you'll see just how we are arranged. We do have a Department of Psychiatry, which is our academic arm, where we do have the privilege of having quite a few psychiatrists, over 110 faculty psychiatrists. We have a big inpatient operation, 168 bed capacity, both adult and child and adolescent units, as well as quite a lot of outpatient and specialty services. So moving on to the next slide. So what's our connection as University of Utah, as UNI, to the rural areas? So I have a plethora of things on the screen, but I'll just go through a couple of these, and then I'm going to dive into the crisis services for a few moments. But we have the opportunity to partner with our rural communities in a variety of ways. We do provide telehealth services where we have been able to see patients in the rural areas using our providers. We've had some good connections there. Just this year, we've launched Call Up. If you don't know what this is, I ask you to find more out about it. There's a link in the slide that we can give you. But this is the consultation access link line to Utah Psychiatry. So we're grateful for our state office here that has funded our program to connect primary care providers with psychiatrists at the university. So we are now taking calls from primary care providers doing consultation on psychiatric conditions. This is for ages up to age 24 at this point, and we'd love to expand that as funding is available. But if you have primary care providers in your community that need help, need resources from a psychiatrist, we would love for you to remind them that this service exists, and it does operate Monday through Friday. We also have our Behavioral Health Echo Series, and this is a case training where providers can get education as well as submit cases to staff cases on a variety of different mental health conditions. We've hosted facilities to come shadow to do some additional education, and we're always open to those arrangements as well. We have our residents and our faculty who are providing clinical rotations in the rural areas. One to highlight, the Southeast Utah Addiction Coalition was a great example of us coming together with rural communities in the Moab, Price, Monticello areas where really talking about addiction. And it was the first time that groups from different organizations had come together to talk about prescribing protocols and how to really deal with addiction among a region with different communities. So that was a great project, and we really learned a lot from that. And then crisis services, I'm gonna jump there. So if you'll go to the next slide. So we have been operating crisis services for Salt Lake County for a while, but in 2018, the legislative session passed HB 41, which created a statewide crisis line through the National Suicide Prevention Lifeline. Up to this point, local mental health authorities had their own crisis line. There were actually upwards of 20 disparate crisis lines throughout the state of Utah. And with this new legislation, UNI was selected to manage the calls, given some of the experience that we had already running a crisis line and a ward line. And as of today, the local mental health authorities are routing crisis callers to the statewide number, in addition to advertising this service. If you go to the next slide, just some data as in terms of 2019 calendar year data. So in affiliation with the National Suicide Prevention Lifeline, our call center answered 63,873 crisis line and lifeline calls for the state of Utah. And I think, so one of the things we were asked to speak about during our part of the presentation was successes. And to me, this is the biggest success that we can demonstrate working as a state, working as communities. And there was a lot of concern, legitimate concern about, calls going to a central place. And it really has only been successful through strong collaboration and relationships. So if we talk about, maybe this is not new to you because it's the key to everything, but relationships and communication and that collaboration really has made this a successful program. And I'm really grateful for the statewide collaboration through the local mental health authorities as well as the state of Utah for making this possible. Okay, let's go on to the next slide. So the other question we were asked to maybe briefly touch on is, what are some of the challenges? And I think hopefully many of you know, so there, I have it on the slide there, the Kempsey Gardner Policy Institute did a in-depth study of Utah's mental health system. This was released in August, and it does a really nice job of going through some of the challenges, particularly here in our state. And so I don't have a lot of time to go through this, but some of the key points of this study says the demand for mental health in Utah is increasing. That's a concern. The shortage of mental health providers is going to continue, and we know that that is even more of a challenge in our rural areas. Funding for the public mental health system is bifurcated across systems, and it does make it difficult to coordinate care. And the two other findings was commercial health insurance is often limited, and there's a little bit more about what an ideal system would include. So we can get the link out to all of you that are on with this report. If you haven't looked at it, it does really go into a lot of depth. And really, I guess for this webinar, it really, one of the graphs in this report shows just the shortage of workforce. And I know you all know that, but I think that as we're talking about challenges, it really is at the key of this. How do we find the providers to provide the service in these rural communities? So with that, I'm going to turn it over to the next presenter.
Janelle, thank you very much. Appreciate the presentation. So let's kind of pass the mic now to Paula Dunham, who's an administrator with Green River. Paula.
Hi, I'm Paula Dunham, the Executive Director of Green River Medical Center. I've asked Amy to show this video clip to give you just a sense of the remoteness. We're located on I-70 and SR6 and 191 in southeastern Utah. We're the only medical care for about 180 miles from Grand Junction, Colorado to Salina, Utah, north-south from Price, Utah down to Moab, Utah, another 120 miles. We're the only healthcare facilities of any sort in that area. And that sense of isolation and remoteness has really affected our behavioral health program. We have a robust, you can go to the next slide, Amy, just briefly, and then move back to my face to help make sense of what I'm saying. We have a robust primary care program. We serve urgent care needs as well as some emergency assistance just because of the distance we are from any other definitive form of healthcare. Significant dental services program that's booked out weeks in advance, even though we just have 6 days per month. But in the area of behavioral health, through the decades, we've found a huge resistance to accessing care. Now in Emory County, we have some of the highest death rates in the state of Utah related to opioid use. We have high suicide rates, depression, mental illness, substance use disorder, family system dysfunction, all indicate that there's a great need for mental health services here in our local area. But probably largely, I mean, there's some part of it that's connected to, we all have a bit of resistance to mental health services, but in this remote setting, really find the dynamic in our community subculture being one where we say we take care of ourselves. We pull ourselves up by our own bootstraps. We don't need head shrinks here. That's been the response through the years. For a couple of decades, Green River Medical Center offered behavioral health services in conjunction with the local mental health authority for 2 days a week. And in 2017, we began to do an analysis, what's working and what's not working. And it was easy to see that there was a small group of a handful of people that we were impacting with those services. But there were a lot of no-show for those type of appointments and just resistance to even scheduling those type of appointments. So as we continued with our analysis, we developed a two-pronged approach to really trying to put behavioral healthcare on the map for what we're not just offering, but completing in the continuum of healthcare services that we offer. The first thing we did was we decided we wanted to have full-time behavioral healthcare in a community of 950 residents. That seemed kind of daunting. But the reality is behavioral health emergencies don't just happen 2 days a week conveniently between 9 and 5 p.m. And so we went to full-time care 5 days a week, hired a full-time therapist, as well as maintained our contract with the local mental health authority so that we had somebody available all of the time that we have our clinic open. The second step that we took was we introduced implemented the concept of integration of behavioral health care into our primary care clinical approach. So this changed our workflow in several ways. Our behavioral health providers, our therapists, meet with the clinical huddle at the beginning of each day. And as they review cases where patients have chronic health issues, or patients who are suffering from multiple comorbidities and could use some counseling related to compliance, patients and identifying patients who had a need throughout the day at the beginning of the day so that the therapist was cued to come in to the clinical appointment for a brief visit. Then we, instead of locating our therapist in their corner office in the back of the building, we actually located them near the exam rooms where the clinical appointments are conducted. And if in the pre-screening of the visit, depression was identified, or suicidal thoughts or feelings was identified, or as the patient began to tell their story to the clinical provider, some sort of emotional elevation happened, frustration with the diagnosis, or just a variety of responses come out of patients when they finally get the doctor's ear, quote unquote. If there was an escalation there, then the provider could step out and motion to the therapist to come join the appointment. And we use the SBIRT model with that. The screening, brief intervention by the therapist, and then referral to ongoing therapy. That usually takes about 5 to 15 minutes during an appointment. And then the clinical provider, while that intervention is taking place, can move on to another patient, another task. And once the situation is de-escalated, the intervention is concluded, the clinical provider comes back in and conducts what is part of their workflow, meeting the needs of the clinical appointment, the primary care appointment that was scheduled. We found, it was really interesting, we were at a place where we were willing to try anything, and any results that were on the level of improving were going to be really encouraging to us. We initiated all of this at the beginning of January in 2019. And in the first quarter alone, we more than doubled the number of encounters with behavioral health therapists and patients over the entire number of encounters for the 2018 calendar year. As we concluded 2019 and did our reporting, we found that we had tripled the number of encounters that we had conducted throughout the year. As providers or behavioral health therapists were able to enter those clinical appointments, a huge, not all, but a huge chunk of that intimidation bias factor was reduced. They could see they were real people without horns on their head. They could have normal conversation with them. Getting assistance, immediate assistance with whatever the issue of the moment was a great step towards trust building. Not everyone immediately makes that appointment for ongoing therapy with the behavioral health providers, but a significant number have, obviously, by the numbers that our reports showed us by the end of the year. You don't overcome bias in a community of any sort, but especially one that's as rural and isolated as ours. You don't overcome all the biases related to mental health care within a year's time, but we've made progress that we feel really happy about and feel like we have a program that is not just addressing the needs that we see, but is addressing the felt needs by the patients in our community.
Paula, thank you. That was great. So let's turn the mic over to Tad Draper, who is a mental health practitioner and counselor from Wayne County. Tad.
Hello. My boss, Evan Christensen, or the director, kind of wanted me to give a viewpoint from a therapist point of view. We're a very unique company. Paula got a lot of the kind of same things we have going. I actually cover Escalante or Garfield County, even though I'm hired for Wayne. But the community, Wayne, or the health center, started about 40 years ago, trying to target the uninsured and underserved. Just because our communities are so rural, they do not have a lot of career paths that include benefits. And so we're able to go in Escalante, and that's about a population of 500-600 people. It's just really small. But we were able to go in there and provide all the medical needs as far as a medical clinic, a dental clinic, and mental health. And we're able to kind of go in and help the uninsured people. For example, if someone's not able to afford anything, they can put on a sliding scale. If they see that prescribing physician, they can go to the pharmacy that's in the same building and go under the 340B option and get the medication at a discounted price or government price or subsidized price. And so he just kind of wanted me to talk a lot about the perspective as far as kind of the biases that we run into. But the company that we work with has really identified quite a bit. We're able to kind of go also into the schools, the rural communities where we're at. You're an hour, hour and a half to the nearest local provider, hospital. Mental health oftentimes is more than 2 hours away. And so we're just kind of able to provide some of that, working through that. We can also telehealth. We have a psychiatrist comes down every month that we can telehealth and coordinate medications with. And surprisingly, in the rural areas that we're at, that we're also hard hit with major things that happen in the urban areas. We had one time where a staff member was killed at a youth program. It made the news, everything. So I was called in to kind of help a lot of the community. We had several community members at the Las Vegas shooting that we worked through with. So we were able to kind of provide a lot of mental health. It's just trying to get people to understand what's there. And as Paula says, they kind of have the attitude of, well, if it's anything to do with mental health, I'm not sure I want to go do that. Or we got some problems that come in where people see each other in the clinic, and it's just so rural that they'll just say, hey, I noticed you in the clinic the other day. How's everything? Or are you all right? But that's kind of what our job, and he just wanted me to talk about from a therapist's point of view. I didn't have the numbers or anything like that everyone else has, but just given a perspective of a therapist. So, Charles, that's about it.
Ted, thank you very much. And I think your clinician view and really being boots on the ground like the rest of you, Paula, Ashley, and Janelle, are tremendously important for this conversation, and thank all of you for that. So you have had an opportunity to hear quite a bit about the value and the importance of community engagement and mental health and overall health promotion and prevention. We've heard about crisis services and the important value of technology and telehealth. We've also heard about the value of kind of integrating primary care and behavioral health care to really help build greater sense of connectivity and openness and safety for clinicians with mental health issues, as well as a number of the challenges from our rural communities in the way of stigma, misperception, access to care, and clearly the importance of the clinicians within our overall healthcare framework. So we have a couple questions for the panelists that I wanted to kind of raise to all of you and hopefully add value to today's webinar. So first, for all of you, how do you see technology, whether it's using the telephone or whether it's using a video platform much like Zoom here, or even apps and smartphones and other types of technology, how do you see that impacting our rural mental health prevention, treatment, and recovery system? Whoever would like to take a first shot.
Yeah. I'll take a shot. I think that technology is really important, especially right now, where, we are doing this entire conference, online using technology. And one thing, that we're seeing, obviously our event next month might not happen. So what are some ways that we can use technology to still reach people? We're working on different kinds of programs, how to get them into into the homes, how to get parents those things, how to get parents the resources, how to link them with telehealth. Also, social media is huge in linking people these days, using social media to put, we use social media to advertise for this conference. So different things like that are huge right now, and I'm just glad that we have these things so that we can use them. And I think that what's going on right now is just kind of, preparing us for what our future may look like.
Yeah, I'll take a stab at it too. Thanks, Ashley. So I think, like you, my viewpoint has changed over the last weeks of the value of technology. I think Locke, who helped put this conference together, said there were 60 people registered for in-person, and I'm looking and we have 124 virtual attendees today. So I think the way we connect could be vastly improved by technology. The one other example I'll just quickly give. So we also, here at the University of Utah, we have a bridge program where patients who are seeking Suboxone treatment can go to our emergency room and get a 1-day supply, and then they follow up within 2 days here at uni. And since this COVID crisis, we have converted those to a virtual follow-up with uni. And it has been far more successful, better, attendance rate, and we're connecting more with these individuals. Whereas before, our perception or our stigma, if we want to bring stigma into this, is, oh, these patients are homeless, they don't have phones, they can't connect, their phones are always minute to minute. We had all of these perceptions, which some of those are true, but our lived experience through technology is that we're having more success with this particular population than we had with in-person. So I think we've learned a lot.
I just would tack in here a little bit. We've had an ongoing relationship with the University of Utah with telepsychiatry, and in conjunction with our local mental health authority, Four Corners Community Behavioral Health, whereby the psychiatrists would hold a quarterly consultation with our clinical providers and patients regarding medication dosages or changes that needed to be made. And that has been a huge benefit to the patients that we were able to place in that program. We haven't, in our rural setting where we're dealing with so many underserved, underinsured patients, we hadn't yet figured out how to make this practical financially for the bulk of the patients whom we serve. Obviously, the last 2 weeks, 3 weeks here at Green River Medical Center, we got forced into a new level of contact with the telehealth world, and we did move as many appointments as we could to telehealth appointments. And we had discussion about what, especially in the area of behavioral health, there's some people that just need those face-to-face consultations. Some of them in our rural setting, there's intimidation factor around technology. A lot of people don't have that smartphone still in a community like ours. But for the ones that do and just had the intimidation factor emotionally around that, we did schedule some appointments where their first appointment, they came in and we actually walked them through the linking process where they were in the room face-to-face with the provider to try to reduce some of that intimidation factor. There's some people that we still just have to see face-to-face to maintain the level of care and support that they need. We're anxious to learn more about what other people are doing.
Great, Paul. Thanks. Tad, anything kind of from your perspective, really in very rural parts of Utah?
I think the access to other professionals as far as case consultation, a lot of things over telehealth or just through social media has been incredible. Instead of going to your conferences, now I can access a lot of people, case consultations, what everybody's seeing up there in a greater number or in a greater area. So it's just been really nice to be able to access a lot of those things.
And Ted, I actually think that you bring up a very good point. As much as we talk about the value of technology for our patients, it's important for us as clinicians, as well as administrators, to have that sense of connectivity, and technology can be that. The University of Utah, as well as the University of Nevada, Reno, have been providing ongoing technology-based training for clinicians, continuing education for clinicians, as well as supervision for clinicians, all of which are free. So that's an added kind of benefit. So the last question I have for the panelists, again, given the fact that our time is getting slim, is kind of from your perspective, what's your secret sauce? What are those key ingredients that you have found within your communities that have really made an impact with regard to mental health treatment and recovery?
I think I alluded to this, so you know, in my presentation, but from a university perspective, our it's not secret, it's communication and collaboration. We're all in this work together, and particularly for the crisis services. You know, this only works because of strong connection and working together. So we can't say enough about how we're all in this together. And even if we're, you know, here in the big city or in rural communities with this technology, we can solve hard problems together. And I think working together is critical.
I think one of the best keys for me has been, I do not actually live in Escalante. I'm from out of town, but I come in each day, which makes it nice because I don't really get out into the community. So people will come in and see me. It's kind of hard if you really know a person inside that community to go to them for mental health. Also, it's been nice that I've been able to go into the schools in the area and kind of help out parents and the students, where before it would just kind of escalate to the courts and then they would go off to residential, where we can kind of minimize that quite a bit. And people are seeing that benefit, as well as the adults in the community. That's really benefited seeing that and being able to work with somebody inside their area.
Thanks, Ted.
This is Paula. The two things I think, one is the collaboration with other mental health care providers. As part of our induction of MAT services here at Green River Medical Center, we became part of the UROC, the Utah Rural Health Opioid Consortium. And the resources that are available to our providers, or that we've learned about that are available to our community members, the brainstorming that takes place at that collaborative level, just the emotional support when we realize that we're not the only ones experiencing the difficulties that we do, that's been really beneficial to us as an organization. And again, for our patients, as I spoke in my portion of the presentation, that brief connection to a behavioral health provider in a non-threatening setting. You know, you're not going to be tied to a couch for an hour appointment saying who knows what. It's just a few minutes of casual conversation with a person who's got some skills to help.
Great, thanks, Paula. Anything you'd like to add, Ashley?
Yeah, I too, the first thing that came to my mind was collaboration. As a prevention specialist, I can't do a lot of my job without linking people from my community. So there are people I need. I need therapists on my team. I can't provide therapy. I need different organizations. I need the hospital on my team. I need, you know, almost every sector working together to provide the resources needed for our community. And so collaboration is huge.
All fantastic points. And thank you all for kind of entertaining a couple of my questions. I am going to kind of move now. We just have a couple minutes left, and kind of welcome any of our audience to ask questions. Feel free to use the question and answer button on the bottom of the screen. You will see on the screen all of our contact information. You are welcome to contact any one of the presenters, including myself, if you have any questions. I have been tracking a number of kind of the chat content, and thank you, Casey, for responding to several of those. And we do have a couple of questions in the queue, so I'm going to go right to them, but feel free to ask any questions if you have something burning. One of the questions for the panel is, how do we engage mental health professionals to pursue training in LGBTQ+ populations and provide gender-affirming care?
I'll take that one. I'm gonna guess this is from my friend Ariel. So Ariel, I hope that's from you. I think this is a really good question. And as we've talked about that as the University of Utah, we've developed, a diversity and inclusion committee that really is helping us tackle that in terms of getting education, awareness, the correct languages to use. And so I think this is a pursuit that we need as leadership in organizations to really ensure that we are valuing that, as well as ensuring that we value that for our clinicians to receive that training. So it's a good question. I'm not sure there's one right answer, but I think it's a continual pursuit, and me as a leader, I have to make that as a commitment and also an expectation for my providers.
Janelle is a great piece. I will add, and by the way, it was Ariel who asked that question. Ariel, feel free to look into either contacting me directly or SAMHSA's website. There are a number of states that actually have moved to specific continuing education competencies or optional expectations for clinicians in states for their licenses in the specific area of working with individuals who are LGBTQ, as well as there is a number of resources concerning specific training platforms that we have been working with the class standards to assure that LGBTQ is included. We have another question, which is, what is the current relationship, and my guess is this is for all of you, that you may have with the Veterans Administration, and how would you leverage joint resources with the VA that are in rural areas?
Charles, that's a good question. I'm currently working with a couple of vets, but they seem to have the ability to come to us on a sliding scale. So I do not have any actual access to Veterans Administration other than giving veterans clinical care. So we have not come up to that issue yet.
Okay. Paula, you're still on mute.
I would tag on there that kind of a ditto of what Tad said. We have a good relationship with the VA resources. Typically, paperwork is completed and transferred back and forth between organizations on behalf of those patients. And then we have obviously the sliding fee scale that we're able to offer as a federally qualified health center, as Wayne Community Health Center does as well, that also reduces fees related to behavioral health care for these special patients.
Janelle, not to put you on the spot, but do you know if there's any particular relationship that the U is engaging with the VA there?
Yeah, we collaborate a lot with the VA, and our residency training program trains a lot of residents over at the VA. I struggle a little answering how that connects back to rural. So I'm not sure I can answer that question today, but I think it's an interesting question to look into and better understand.
And it may be a great opportunity for the Utah Rural Health Association to begin to kind of engage with, obviously, partners. Several of you represent partner organizations for the state, to really kind of bring the VA into that conversation and think about how best to marry and support veterans that have mental health issues that may not be living in our urban or suburban areas of Utah. And there are a number of kind of examples around the country where the VA has made that connection, and obviously that might be a great kind of next step for the Utah Rural Health Association to move toward. So I am being kind of very observant at time. Otherwise, I may end up getting the hook, or we may end up getting the hook for all the panelists. But want to thank all the panelists for their tremendous time, commitment, and clear energy and passion and expertise in this area. And thank you for your contributions. Definitely want to thank the entire audience for participating. A couple of the chat observations just kind of confirmed just the value of this type of platform to actually connecting individuals and communicating valuable information. We encourage you to stay in touch with the Utah Rural Health Association, as well as encourage you to kind of lean back on us and see if there are particular areas where we may be able to assist, and you have our contact information for that. So I wish you a wonderful rest of your Friday, a very wonderful weekend, happy Easter, and may the best be with you. Thank you.